Greetings. My name is Steve Short. I'm a physical therapist and vice president of sports medicine with the Denver Nuggets basketball team. I would like to extend a thank you to the Academy of Orthopedic Physical Therapy and the Foot and Ankle Special Interest Group in inviting me to talk about lateral ankle sprains. So we're going to be talking about current concepts in lateral ankle sprains and return to play. Jumping in, just a few objectives for your time here today. We want to review the pathoanatomics related to this injury and how that impacts the impairments that we're treating. Run through just the fundamentals of what happens when we sprain our ankles on the lateral side. Utilize some clinical reasoning to progress through criteria. Work our way through that return to play performance continuum and address some considerations to prevention both before and after these ankle sprain cases. So as we all know, and just a reminder here, inversion with varying degrees of plantar flexion is the common mechanism of injury for these ankle sprains. The involved ligaments are often the anterior talofibular ligament or the calcaneofibular ligament. Less often involved and would probably have a more degree of dorsiflexion with inversion would be that posterior talofibular ligament. Other things that we may see when we sprain our ankle are various degrees of bone bruising, soft tissue strain across the spectrum. When this ankle inversion happens, obviously there's going to be an appropriate and expected amount of pain and swelling that occurs. And inevitably, when that patient comes across your training or clinic room table, they're going to ask, do I need an x-ray? And with the great access that we have with direct access, or many of us physical therapists are practicing in a training room in a sports setting, we need to be very familiar with the Ottawa ankle rules. Noting that these rules are 96 to 99% sensitive in helping us diagnose whether we need to get an x-ray or not. A few key points within these Ottawa rules and what we're looking for is tenderness, both on the lateral and medial zones, the malleolar zones. And then we also want to consider any tenderness to the midfoot region, both at the lateral fifth metatarsal or the base of the fifth metatarsal and at the navicular. Another key pearl within that is our weight-bearing status, both the inability to bear weight initially at the time of sprain if we're doing some event coverage, and also when they're reporting to the emergency room, which is how the study was conducted, or within the clinic a few hours later. And that inability and tenderness at those areas is going to account for the need for an x-ray and radiographs. So assuming that those radiographs are negative, we want to grade the degree of sprain. Obviously, magnetic resonance imaging is going to be a useful diagnostic if we need a better look at those ligaments and the associated structures that may be involved, be it bone bruising or cartilaginous injuries, or some soft tissue strain about some of the other regional structures. But looking at things clinically, we can have a good hypothesis of what that MRI is going to look like based on our level of weight bearing and pain. So if we're not having any issues and there's minimal swelling, we're assuming that that's probably going to be a lower grade sprain, closer to that grade 1. If we're looking at mild pain with weight bearing and some moderate swelling and ecchymosis, looking at that grade 2 partial sprains or partial tearing. And then when our swelling is severe and weight bearing is difficult, maybe you referred because Ottawa rules were positive, but they were negative for fracture, we're looking at closer to that grade 3 sprain. That's going to affect our timeline a little bit in terms of what we're expected to do when we look at that ESPN ticker and we look at just the classic tissue healing. We know that when a ligament is disrupted, that tissue is probably going to be changed to some degree forever. And it's going to take a good 21 days to create a decent callus, and that fiber type is, again, going to be changed forever and is going to be remodeling up to a year and maybe even beyond. And those fibers may be in some way, shape, or form disorganized and never quite the same. And that textbook tissue healing that is expected generally is pretty consistent. And it's why we can say that in 3 to 6 weeks that grade 2 or grade 3 sprain might be back. But then we have a whole other host of issues that help us impact a successful or maybe not so successful ankle sprain. It might be prior sprains before and chronic recurrent instability. It might be pressure from coaches. It might be pressures from parents or other external factors. It might be the fact that the athlete may or may not enjoy the sport very much. It might be the fact that they can't restore pain-free strength. There's multiple factors that we need to navigate. And so in order for us to navigate a lot of these considerations, we need some criteria to help us improve our clinical decision making. And so we want to look within various different constructs, be it mobility, strength, power, balance, or motor control, various special testings, sport-specific conditioning to give us an idea of where our impairments are at, how we're progressing through our expected timeline that goes along with biological healing, and how well that they're going to tolerate and how well that they've made improvements so that we can get them back out onto the court safely and make this recent sprain a distant memory. It's important to note too that we have good tests and measures within all of our constructs. We don't want to perseverate on the testing, but we want to get a good idea of what we're working with. So if we're looking at restoring ankle dorsiflexion, we might want to institute a weight-bearing ankle dorsiflexion test, institute our stretches and strengthening, retest down the way. We're not getting hung up on the test. We're getting hung up on the training that is required to restore that goal and retesting at appropriate time. Same thing goes for strength measures, right? We need an appropriate, maybe isolated isometric test, such as a isometric ankle eversion test, or maybe it's a brake test assessing that eccentric eversion strength to resist that ankle inversion, and also looking at compound movements. And that progresses along as we get more and more bells and whistles. We might be looking at what their jump and force profile looks like on a force plate. We may or may not be filming that. We're getting their subjective reports along with how that goes. Y balance allows us to assess, or star excursion within the same family allows us to assess some strength and motor control within that, and gives us a nice objective measure to track along the way. And the list goes on. And we want to be checking these buckets as we progress through our rehab program. What does our rehab program look like? Well, if we zoom out, we're going to have 3 to 5 phases, depending on how you decide to design your program, with the expected timeline of anywhere from 0 to 6 weeks, depending on the degree of sprain. We might use a 3-staged return to play progression. This is in the vein of perhaps some of our strength conditioning periodization techniques, where we're grading different phases and having different objectives within this phase. So if we're looking at a 3-phased program, say in an example of a grade 2 sprain, we're going to attack a couple different impairments in the acute phase. Mainly, we're going to be managing swelling and pain with the goal to get them walking normally and restore just some daily function. So having some gait and balance goals and their related impairments that we've tested out are going to be what we want to attack. Intervention, of course, and this is going to be pretty similar, just scalar across the spectrum. We want to provide good reassurance across the spectrum, knowing that we're going to detail what their rehab is going to look like, when they're going to be expected to be feeling better, and making sure that we get good sign-off and consent on the types of interventions that we're going to be doing. Some adjuncts or modalities that might help nudge some of that pain and swelling in the right direction might be a boot, a brace, or some tape just to take off, add some support and stability as we're restoring gait and getting them out of those as quickly and as safely as we possibly can. Compression and certain types of pain control, such as cryotherapies or manual therapies, are totally appropriate. We know that manual therapy has good evidence to help nudge outcomes along earlier and faster, and utilizing some of those techniques can give the patient some confidence and some improved pain management to get them moving early per their tolerance. So what do a few of those techniques look like? We might utilize something like a anterior to posterior mobilization, or anterior posterior pressure with immobilization with movement. And then also noting that our strengthening exercises, not just classic stretching, but our strengthening exercises, so something like a local four-way ankle or doing some eccentric heel raises per tolerance, you may be even adding that not just on a level ground, but to a step. Coupling that with some tempo movements, so a nice slow 0 to 4 or 6 second descent count, and dipping into a little bit more ankle dorsiflexion than the picture allows here, may allow us to get some stretching under tension and increase some mobility that way in the acute phase. As we look on into the subacute phase, and if we're hypothetically dealing with a grade 2 or 3 sprain, we're still going to be dealing with some swelling and pain. And it's important that we educate the patient that this is normal. Our gait may be improving and our balance may be improving, but we're still going to be looking on those things. And our gait may progress from just a basic walk into some jogging or light linear running, depending on our pain presentation. We're also going to be doing some more proper strengthening and mobility exercises and transitioning into attacking some power output deficits or rate of force development that may be lost. Also, we may be doing some intro to hopping and more progressive single leg exercises to make our stability in a single leg a bit more challenging. So if we're within our own individual exercise paradigms, we might decide to group our exercises in something like this, still focusing in on building up local strength, so increasing bands or doing it on an isokinetic machine or adding weight or doing more manual brake tests are all totally appropriate if we're addressing ankle exercise just at the ankle. Progressing through and adding weight per tolerance on compound movements. Maybe we break that in a lower extremity day down to hinge or hip dominant movements and also knee or squat dominant movements, and adding weight as we go to really get a strength base going. We can progress that through fatigue. We can progress that through 3 to 5 sets of 6 to 12, 15 repetitions, matching that volume to intensity and ensuring that maybe we're working 70% 1 rep max or more. In that terminal phase, again, we may still have some persistent swelling, and we're balancing through the START framework of how we're going to return to play. And so progressing activities appropriately with the adequate amount of risk assessment and knowing that some of that persistent swelling or joint loss or range of motion loss is persistent, and we're going to want to navigate that and continue to address that. But the activities that we're doing, be it returning to limited practice, increased intensities of individual drills, progressing through plyometric programs, are all happening. So we're doing that and making sure that with our tests that we've identified and test and retest that we're not regressing in any of our constructs, that our pain is hopefully not worsening from session to session or within session, and that we can keep loading the athlete in all of those different parameters. So different drills, we may be transitioning to different power outputs such as kettlebell swings, medicine ball throws. We're transitioning into triplanar demands, doing various degrees of plyometric drills, single leg hops in different directions, making that reactive. Obviously increasing the speeds within our running, tolerating sprinting, changes of direction, sport-specific tasks such as finishing at a rim in basketball, kicking in soccer, juke moves in American football, you name it, we can do it. And really what you're doing within that, you can pick a shape, a direction, a size. There's lots of different clinical measures and tests. Pick one that works within your paradigm and get them moving. Train that and retest it. And again, as the weeks go by, hopefully we are improving in all of those That goes without saying that a lot of these drills, no matter how much we want to try to recreate function or sport, you cannot replace playing the actual sport. So we need to be communicating with athletic trainers, strength and conditioning coaches, sport coaches, management, whatever it may be, and tracking the appropriate reintroduction to sport and doing that as early as we safely can. If we look at some current phrasing within the return to sport continuum, the athlete may return to participation, but not necessarily to sport. So getting them in controlled individual drills, be it through the controlled chaos continuum, a recent article was posted in JOSPT, or linear to lateral progressions that are a little bit more traditional. Whatever your paradigm is, we're working to get them participating in a safe and controlled fashion as early as we can to build up their sport-specific reconditioning callus. Once they've returned to sport, they may not have returned to their optimal highest level performance. So they might be playing sport that's scrimmaging in practice, but they still haven't been cleared for competition. And again, building up that reconditioning callus all along with all of the drills that we've talked about in the respective rehabilitation phases. Finally, and ultimately, we want to return to performance. That is the goal, get everybody performing to their highest level possible. And we can't do that without them playing their sport. So again, our tests and our retests within our clinical measures are of the utmost importance, and we want to sync that in as harmoniously as possible with all of the sporting activity that we are supervising. What is encouraging across the constructs that we're testing is that a group of researchers and experts in the field all got together. They put together a bunch of categories that they deemed highly important in returning from a lateral ankle sprain, and that includes the pain severity, the impairments, which include ankle range of motion, muscle strength and power, the athlete perception, their motor control, both in a static and dynamic situation, and their functional performance that includes playing the sport, as we just discussed, and a lot of those hopping drills that we had diagrams for, and their sport-specific activity. Now, mind you, this is only expert opinion and criteria that was recommended for athletes to go through. Hot off the presses and ahead of print in Sports Health, so coming out, look on your calendars, mark it out there, 2023, is the ankle GO score. Again, a lot of the constructs and clinical tests are ones that we discussed, such as the Y balance and various degrees of hop tests. This, when applied, has been shown to identify those who have returned to sport and returned to sport at higher levels of function. So those who have tested higher in their related categories, be it perceived function through patient-reported outcome measures, Y balance or star excursion measures, and different hop tests. The better you perform at those, the better you are at returning to sport, if you do even return to sport at all. So what we are seeing is the emergence of and the support of testing and training within these various degrees of constructs. Now, we want to maximize our rehab, and we want to make sure that we're doing everything that we can do to ensure that this doesn't happen again. However, going back out there in sport, in sport at the highest level, or even at the various degrees of levels leading up to the highest level, has been shown that ankle sprains, unfortunately, do reoccur. We can look at this article from Herzog that was published in the National Basketball Association, and that younger athletes tend to incur more and more ankle sprains, and that the odds of that ankle sprain happening both on that limb and or the other limb within a calendar year is significantly higher than those who have not sprained their ankle previously. So we need to investigate different degrees of injury prevention, both before the athletes go out and incur an ankle sprain and throughout their rehab program and when they return to sport. Thankfully, we have our handy-dandy clinical practice guidelines that came out in 2001, so please go reassess that at jospt.org and review that for when we're treating our ankle sprains, and that's where this figure came from. When we look at primary prevention before an injury occurred, we may be able to do some training through therapeutic exercise 2 to 3 times a week, 15 to 30 minutes within each individual session of varying degrees of strengthening proprioceptive exercises. We may be wanting to do that, but what we do have the strongest support for is prophylactic bracing before an injury occurs. Now, once an injury occurs and we want to reduce the risk of a future ankle sprain, we're definitely wanting, and we know that there's high levels of evidence to support both those exercise programs that we just discussed throughout this presentation and prophylactic bracing. Once we are in that sprained state of injury, we definitely want to support early weight bearing and getting things moving to have superior outcomes. Again, that therapeutic exercise program and manual therapy to nudge things in the right direction. That's what we know has the best evidence to support. We may, with varying degrees, as we discussed, and no surprise there that that our directives came from the clinical practice guidelines, varying degrees of compression, ice, and other modalities, and so forth. Once again, tertiary prevention, so above and beyond and at the end stages of rehab. So after rehab has ended, we've made that return to performance, we've hit that end stage continuum. We want to continue with varying degrees of therapeutic exercise, manual therapy, PRN, and combined treatment programs. We definitely know that we don't want external support a la bracing and taping to be the only thing that we're doing in those stages, and that there's adjuncts due to chronic proprioceptive deficits, losses of ankle dorsiflexion, losses in plantar flexion and eversion strength, knowing that the fact that the status of the joint within the synovium and inflammatory markers in the synovium after a large degree sprain have long lingering effects. And so we know those deficits are going to be present years after. And so our exercise and preventative measures should match those known deficits. Once again, I reinforce that everyone go out and read these clinical practice guidelines. They're constantly updated and staying tuned in with the evidence, staying tuned in with the great resources that we have within the foot and ankle special interest groups, be it on social medias, be it at our conferences, and always being an advocate to push the envelope. No different than early motion in our ankle sprained athletes and patients. We want to be early advocates of the evidence and push the avenues forward, just like the articles that we discussed, so we can get better outcomes and keep people on their feet, jumping higher, running faster, and pushing the envelope. Once again, a big time thank you for tuning in. A big time thank you for the opportunity to speak to you, and I look forward to what the next update brings. Onwards.